Good morning, good afternoon, and good evening to everyone. Thank you for joining our discussion today on the promise of contraceptive self-injection and evidence from Uganda. PATH believes that an expanded range of contraceptive options will help each woman find the product and approach that works best for her at different stages of her life. Imagine a world in which women can go to a rural clinic or a drug shop, take home a few units of injectable contraception, and have a year of protection from unintended pregnancy. The words here of one of our research participants in Uganda summarizes the promise of self-injection quite well. Self-injection can save women time and money by reducing clinic visits. It may also save money for health systems. Self-injection can increase women's autonomy so that a woman can choose when and where to inject based on her own needs. So you'll be hearing about these ideas more today in our webinar. I'm Jen Kidwell-Drake, Assistant Director of PATH's Diana Press project in our reproductive health program, and I'll be moderating today's discussion. Jane Cover, PATH's Diana Press Research Manager, will kick things off today. Jane will share background on the first self-injectable contraceptive product available in sub-Saharan Africa and many other places. The product is known by its brand name, Diana Press, and by its generic name, DMPA-SC or DMPA sub-Q. It's delivered in the Uniject injection system. After Jane, Alan Namagembe, PATH's research lead in Uganda, will present the findings from our self-injection feasibility study conducted in collaboration with the Ministry of Health. During the presentations, you are welcome to send questions using the chat feature on your computer. We'll be collecting these questions as they come in, and after the presentations, we'll have a question and answer session during which the presenters will address your questions. So now I'll turn it over to Jane.
Thank you, Jen. So before turning to self-injection, and for those who may not be familiar with DMPA-SC, often known by its brand name Diana Press, let me take a moment to run through how this injectable differs from the traditional DMPA-IM, often known by the most common version, Depo-Provera. Diana Press is a subcutaneous version of the traditional intramuscular depo-medroxyprogesterone acetate in the vial and syringe. It has the same safety and efficacy profile, but at a 30% lower dose. Like DMPA-IM, it is stored at room temperature. The all-in-one Uniject device makes it easy to administer without a great deal of training and makes self-injection possible. As many of you know, injectable contraception is enormously popular throughout much of Africa, representing more than 50% of the contraceptive method mix in Uganda. It's popular because it offers discreet, effective, short-term, and safe pregnancy prevention. However, injectable contraception requires clinic visits or community health worker visits, depending on the context, every 3 months, so 4 times a year, which increases cost to women in time and travel. Self-injection may improve access and continuation of injectable contraception, particularly for women living far from clinics and community health workers. Next slide. So how do the features of DMPA-SC translate into benefits for women and healthcare programs? The single exact dose with the all-in-one presentation and the subcutaneous injection offers the benefit of a simplified injection procedure, a simpler and shorter training, and eliminates the mismatch of syringe and vial supplies. DMPA-SC weighs less and requires less space in the shipping container, on the delivery truck, or on the shelf, which translates into cheaper and easier transportation and storage. And there is less waste for disposal. Finally, because it is non-reusable, it improves injection safety. These features and benefits result in high acceptability among lower-level healthcare workers and make it uniquely suited for self-injection. To date, nearly 500,000 doses have been administered by providers in the 4 countries where Cyanopress was first introduced, from July 2014 to June 2016. Those countries are Senegal, Burkina Faso, Niger, and Uganda. The product is now available for administration by providers in about 15 countries and is on the brink of introduction in many others. In Uganda, the Ministry of Health, PATH, and partners trained more than 2,000 community health workers to administer both DMPA-IM and DMPA-SC injections, starting in 2014. This map shows the districts where DMPA-SC was introduced and the partners involved in that introduction. So where do we stand with respect to DMPA-SC in Uganda? As I said, it was introduced through community health workers in 2014. And in that introduction, more than 130,000 doses were administered, and 29% of those doses were administered to new users who had never used family planning previously. 44% of those doses were administered to women who were under age 25, so to youth. National scale-up planning is in process in Uganda, and it is now offered at clinics in many of those districts. Self-injection research has been undertaken to examine the feasibility of self-injection, which is, of course, the study you'll hear about shortly. Another study is underway looking at whether self-injection improves injectable continuation. And a self-injection pilot has just begun in one district. Before we turn to the study in Uganda, let me take you on a brief tour of the self-injection literature to date, because there have been a number of promising but small studies. Studies took place in Scotland, the US, in Florida and New York, and in the Americas as part of the original clinical trials for Cyanopress. These studies found that most women, between 87 and 90%, report that self-injection is easy to do. Most wanted to continue, around 95%, or would recommend it to others, 94%. There were no serious adverse events or pregnancies across all these studies, although I would note that these studies have small sample sizes. No self-injection study had been conducted in sub-Saharan Africa until 2015. And the results that we'll share with you today are from that first study. Where do we stand with respect to the regulatory environment for self-injection? In September 2015, Pfizer announced the approval of self-injection from the UK Medicines and Healthcare Products Regulatory Agency, the MHRA. And what you see on the slide is that Pfizer press release. Pfizer is applying for the same label change in a number of additional countries. In Uganda, the National Drug Authority has conditionally approved the self-injection label change. And the label change has already been approved in Niger, Nigeria, and Ghana. In a 2015 publication on safe abortion care and post-abortion contraception, the World Health Organization recommended self-administration of injectable contraception, and I quote, in contexts where mechanisms to provide the woman with appropriate information and training exist, referral linkages to a healthcare provider are strong, and where monitoring and follow-up can be ensured, unquote. This slide shows the WHO recommendation, which is found in Table 21 of that publication. In summary, around the time PATH initiated our self-injection research, the evidence for self-injection was pretty good. Good enough for a UK stringent regulatory authority and the WHO to give self-injection a green light, or at least a blinking yellow light in the case of the WHO. But there wasn't any actual experience with self-injection documented in sub-Saharan Africa. We talked with the MOHs, the Ministries of Health in Senegal and Uganda, and agreed that we all wanted to understand about whether women in those settings liked self-injection, whether it was feasible for them to self-inject, how self-injection programs could be designed to support women to succeed, and finally, whether self-injection could improve contraceptive continuation and cost effectiveness. What is a potential pathway towards scale-up of self-injection in Uganda? We started with a successful pilot introduction of DMPA-SC administered by community health workers. That pilot was popular with the workers and reached a substantial share of new users and youth. We learned, based on our research, that self-injection in Uganda appears to be feasible and acceptable. In Q3 of 2016, the Ministry of Health authorized a pilot of self-injection in one district, and the National Drug Authority conditionally approved self-injection. So what are the critical next steps? First, expansion and evaluation of self-injection in more geographies and delivery channels, and outside of a research setting. Here the key question is, how do we advance from a research study, which is a very controlled and regimented environment, towards a scaled-up program? So as self-injection is rolled out in 3 districts, we'll be evaluating very carefully to understand what are the quote-unquote best practices for a self-injection program that will optimize women's success in a cost-efficient way. And the outcome of that, we hope, will be a policy change that enables scale-up of self-injection. Of course, for the country to go to scale, they will need ongoing access to the product and donor support. So with that rather long introduction, I now want to turn over the presentation to Alan Namagembe, who will be presenting from Uganda. She is the co-investigator who oversaw the research that you're going to learn about in Uganda. Alan?
Thank you, Jen. I'm presenting the design and results of the PATH Ministry of Health feasibility and acceptability of self-injection in Uganda. We had 2 primary outcomes, and one was % of women who demonstrate injection competence at 3 months. And second, % of women who inject on time within 1 week before or after their injection date. We also had 2 secondary outcomes. One was to identify operational considerations for the design of our future self-injection program, and these considerations included challenges with injection steps that may need extra attention during training, adequacy of training and use of the client instruction booklet, reliance on lay caregivers. These included family members or community health workers or providers for assistance, storage of the Sayana press units, and disposal of the used devices. The other secondary outcome was to assess the acceptability of self-injection and identify the characteristics of women for whom self-injection is appealing or not. Next. Next. So our research approach, the study design was a prospective observational study with women who tried self-injection, and the sample size was 380. Interviews were also conducted with women who declined self-injection, who we referred to as refusers, and the sample size for those women was 62. Study procedures. Women were trained in self-injection and practiced injections on a model. This was a condom filled with salt. They self-injected under the supervision of a study nurse who used an observation checklist to evaluate their injection technique. And the observation checklist really included steps that one needs to take to successfully self-inject. Those judged competent were given 1 Sayana press unit to take home to self-inject without the supervision of a study nurse. Then women who declined to try self-injection were interviewed to understand why they opted out. Self-injectors were followed up after 3 months or later at home after their injection date. They were asked to demonstrate on the model the injection steps and were interviewed again. Women were not observed giving their second injection at home. Rather, they were followed up after their injection date that had passed and asked to demonstrate their injection technique on a model. The study was structured without direct observation of the second injection so that we could also evaluate whether she gave the injection on time. Next. Next slide, yes. The key challenge was the time lag between initial self-injection training and unsupervised self-injection. That is 3 months later. So PATH developed a one-on-one training. Go back to the previous slide, please. PATH developed a one-on-one training approach intended to foster independence. Central to the training is our client instruction booklet with detailed visual images designed with non-illiterate women in mind to serve as a memory aid. In the pictures on the slide is a study nurse conducting a one-on-one training, and then samples of the client booklets translated into the local language. The training and booklet focus not only on injection technique, but also on how to store the product safely at home, how to dispose the used device, and when to re-inject. We also use the opportunity to remind women of the injectable contraception side effects and of the need to use condoms if at risk of HIV. Next. So here we're going to look at the results, injection competence, and training. To qualify as competent, participants must succeed at 5 critical steps, and these included choosing an appropriate injection site, mixing the solution, activating the Uniject device, creating a tent in the skin, and pressing the reservoir slowly. These steps were defined as critical based on the idea that if not completed correctly, the injection might not be effective. Note that the injection timing is a very conservative measure, since the reinjection window for DMPA is very forgiving. It is 2 weeks before and 4 weeks after, but we considered 1 week before and 1 week after. We timed the follow-up visits to fall well within the reinjection window so that if a woman had forgotten to inject, she would still be able to do so and would be protected from pregnancy in the interim. Because of the follow-up schedule, while we were easily able to see if a woman reinjected too early, that is more than 2 weeks, we were not able to assess whether she would have remembered the injection had the follow-up visit not occurred. So that said, at the time of the follow-up, only 6 women had not yet self-injected and were therefore at risk of forgetting. And if you look at the results, 97.9% of the women were competent at first injection, 88% were competent after 3 months, that is during the second injection, and 95% injected on time, and 86.9% injected both on time and were competent at the technique. All but 3 women were given, of the injections were given within the WHO recommended reinjection window of DMPA. Next. So profiles of women deemed competent vis-a-vis not competent. So if you look at this slide, we are comparing the characteristics of women who demonstrated competence and women who did not. The bolded numbers are the only significant differences between the two groups. And you can see that women with more years of education tended to fall into the competent group, and women who had never been to school at all tended to fall into the competent group. Other characteristics like age or contraceptive experience were not statistically significantly different. Next slide. Well, we were also interested in what we term operational considerations. That is, which things you want to know if you are going to launch a self-injection program. Ease of injection and challenges with the injection steps. 92% of women called self-injection very easy after the second injection, and 61% after the first injection. Women who found self-injection difficult identified pressing the reservoir as the most challenging step. Pressing the reservoir might be difficult because women are trying to press too quickly. They should be taking about 5 to 7 seconds to press. So self-injection programs should put extra emphasis on training women to press the reservoir slowly. Adequacy of training. All but 8 women felt adequately prepared to do self-injection independently after training. It's important to note that women practiced injections about 2.7 times before injecting themselves the first time. Almost all women, 95.6%, relied on the instruction booklet for re-injection. And reliance on caregivers or providers for injection assistance. All women, save for one, reported that they gave themselves the injection. Next slide. After self-injecting for the first time, women were asked how confident they were that they knew when to re-inject and how to schedule the subsequent injection. 69.9% were very confident that they knew how to do this. The vast majority of the women who re-injected, that is 95%, gave the shot within the 1 week of the re-injection date. Next slide. At the follow-up visit, women were asked to provide the date for their injection, that is the third injection, if they knew it. 92.5% had calculated the date correctly. 4.2% had calculated it wrongly. And 3.3% did not know the next injection date. Next slide. So before we discuss storage at home, some context is important. And in our study, about a quarter of the women in the self-injecting group reported that their husband or partner did not support their use of family planning. So storage was important, and 97.5% of women reported that they were able to keep the cyanopress unit secure, free from discovery by children or others. The most commonly mentioned storage places were handbags at 61.3% and suitcases at 21.2%. Disposal. Women were advised to place the spent device in a permeable container with a lid, such as an empty water bottle, a plastic one, a Vaseline jar, then to either return the spent Uniject device to the clinic or to the study nurse, or to discard the device in a pit latrine, retaining the container. And if we look at that data, 93.8% threw it into the latrine, 5.7% returned it to the clinic, and 0.6% put it in the household garbage. 71.5% of women reported that they placed the spent Uniject device immediately into a lidded container until they could dispose of it, which was what we really emphasized during the training. Next. For this study, in addition to self-injection group, we also sampled a small group of women who declined to self-inject. We wanted to better understand what differentiates clients who are interested in self-injection from those who are not interested. Findings that are significant at conventional levels of less than 0.0% are bolded, and I'll focus on those results. Contraceptive experience. Women who have previously discontinued injectable use were disproportionately represented in the self-injection group, and similarly, women in the self-injection group have more experience with a range of methods than women in the refusal group. Second, women who paid for their transportation to reach the clinic and those who paid more for transportation were more likely to opt for self-injection. And not surprisingly, self-injectors were less anxious about needles and injections. What we didn't find are differences in social demographic characteristics such as age, education level, parity, or marital status. Nor are self-injecting women were more concerned with confidentiality, nor do they exhibit greater decision-making, autonomy, or have more or less supportive social networks for use or family planning. Next slide. Among women followed up after the 3 months, nearly all, that is 97.8%, would like to continue the self-injection if it were available. And all but 4 would recommend self-injection to others. And 3 out of those who couldn't recommend, 3 were unlikely in absolute figures. Next slide. Next slide, please. Yes, this slide shows us some quotes from the women. Among the self-injectors, one woman said, "It is secretive, it does not consume money, and does not waste time." Another one said, "It saves time of waiting at the hospital for a provider. I overcome missing my dose due to stockouts, because with this, I keep my medicine with me." Another one mentioned that, "I do not need to travel long distance. It is easy, safe, and gives me the freedom to manage it myself." Next slide. Among the refusers, these were some of the quotes. "Within me, I feel shaky. Let me call it shaking internally. I am a coward when it comes to injections." Another one said, "If I see someone else using it who does not get problems, I'll come with my husband for training. And if I'm unable to inject myself, then my husband can do it." Another one quoted to have said, "If I have learned how to give myself the injection, apart from fear of my husband, I can keep it with my neighbor. I run there and inject myself, then I come back and sit. Next slide. So look at the implications for self-injection program design in Uganda. Who can learn to self-inject? Women with only primary education are fully capable of self-injection. Women who have never been to school may need extra support. And young women are equally competent as more mature women, since there's really no difference between age. Women who have never used family planning, press, or the injectable were equally competent. What are the implications for training? Careful review of the injection steps seems to help women self-inject independently, especially non-literate women. Practice on the model was helpful. On average, women practiced about 3 times. What support is necessary? Women's comfort with giving themselves the injection suggests that program may not want to focus resources on training additional family members as lay caregivers. And if programs wish to encourage a larger share of women to self-inject, training a family member or a community health worker could increase the percentage of women self-injecting. But the anxiety of women who are initially reluctant may not be overcome. So another option would be to link up new self-injectors with experienced self-injectors in the community who could serve as helpers for the first independent injection. This strategy might be particularly helpful for women who have not been to school. The heavy reliance on the instruction booklet suggests that it is instrumental as a memory aid. If not using a visual guide, programs may need to find other mechanisms to support women as they do their first independent injection. And reminder that this study only involved one unsupervised injection. Women may have additional needs that emerge over time and require ongoing support. Next slide. What reminders are needed? Writing future injection dates in the booklet may be sufficient. And while probably helpful, reminder systems, that is phone, text messages, may not be feasible. Is storage a problem? Women who chose to self-inject were able to store the press securely at home and had no problems or challenges. So disposal, latrine disposal is not an ideal strategy, yet it serves to remove the spent device from risk of contact quickly and does not require a woman to return the device to the clinic. Whatever strategy is used, we don't want to undermine the motivation to self-inject by requiring to return to the clinic. Note that not every urban or rural woman will have access to a pit latrine. And the importance of securing the spent device in a puncture-proof household container should be another point to emphasize for the design of a future self-injection program. Next. In conclusion, self-injection is feasible and highly acceptable among this group of relatively rural Ugandan women. Convenience and cost savings seem to be a major motivator. Women who pay for transport to clinics and whose transportation costs are higher are more likely to try self-injection. Based on these findings and the Ministry of Health approval, self-injection was rolled out in late 2016 on a pilot basis in one district of Uganda, with plans to roll out in additional districts in 2017. Next. This work was supported by funding from the Bill and Melinda Gates Foundation and the Children's Investment Fund Foundation. Thank you for your attention. So I'll hand over to Jen.
Thanks, Alan. Thank you so much to Alan and Jane for those presentations. And thanks to all of you who sent in questions. It's really exciting to see how much interest there is in this topic. So we're going to give Jane and Alan a chance to answer your questions. We have a lot, so we will do our very best to get to all of them. If we don't have the chance to answer your question, you can feel free to send us an email at cyanapress@path.org after this webinar. I first want to just address one question that was submitted, which was whether we could share a soft copy of the client booklet. And you can find that on our website, and the link right now should be on your screen. It's sites.path.org/ I'm not going to say all those things, but that's what the web link is. There are a variety of resources. If you go to the section on self-injection, you'll find links to our client booklet. So the first question I'm going to refer is to Jane, and we have a participant who would like to know what the efficacy rate is for Cyanopress.
So the efficacy rate for Cyanopress is 99% if it's used consistently, which means a woman is going every 3 months for her injection.
Great. Thank you, Jane. The next question is for Alan. And Alan, one of our participants would like to know what the status of use of Depo-Provera in Uganda is after the introduction of Cyanopress, and how the introduction of Cyanopress has affected the use of Depo-Provera or DMPA-IM.
Yeah, Cyanopress has been attracted many new users, although there are also some switching. Initially, when we had just introduced Cyanopress in Uganda, the switching was high, but it is kind of now leveling.
Great. Thanks, Alan. So the next question is for Jane. And one of our participants would like to know if there are any data available on different age groups in terms of acceptability and interest. It says in this method, so I'm going to ask you to talk about the method itself, Cyanopress or DMPA-SC, as well as self-injection specifically.
Sure. So we've also completed in Uganda an adolescent acceptability study that is a qualitative piece of work where we did in-depth interviews with adolescents 15 to 19 about injectable use, use of Cyanopress, and a self-injection. And just to clarify, there was no actual self-injection that took place during this study. It was all hypothetical. And those results are not yet published, but will be soon. But just to give you a glimpse of that, what we learned was that there are lots of concerns about adolescent use of the injectable more generally. And those concerns most often are about potential risk to her future fertility by using the injectable. So in this study, we talked with both providers and adolescents, and a substantial number of both of those groups had concerns about future fertility, which of course, as you probably know, use of the injectable does not impact your fertility. So that affects the use of Cyanopress, obviously, and has lots of implications for the product as well as future self-injection. Now, that said, there was also a substantial share of adolescents who were very interested in self-injection and the potential for self-injection to both in terms of saving money and time, as well as increased confidentiality and discretion, because as you probably know, adolescents in many contexts face a lot of stigma in going to a clinic to get methods. So there was both this concern about the injectable use more generally, as well as interest in self-injection.
Great. Thank you, Jane. The next question is for Alan. So Alan, can you speak to whether there were any issues related to injection safety in the home and in the community during the study?
Nothing was reported, but I should also say this was very short. Women only carried one unit home, and the follow-up was also soon. So those who were found to have any used device that is not disposed of was picked up by the study nurse.
Thanks, Alan. And now, Jane, I have a couple questions actually about training. So somebody asked whether every client required training before first self-injection, and then would like to understand more about how we might in the future train large groups of clients. Related to that, somebody specifically asked whether the training for this study was done in a group session or one-on-one session, and what would be most feasible. So can you speak to those issues?
Yeah, that's a great question. So because this was a research study, it's very structured and regimented, not all that similar to what would likely happen in a clinic setting. We did one-on-one training sessions with women, and they were able to practice for as long as they wanted to before they gave themselves the injection. So that's probably not very realistic or practical for a very busy clinic setting. What we'd like to do as we roll out in Uganda is to vary that training and to try some group training, and then do a comparison and evaluate systematically whether women who are trained in a group are equally successful or proficient at self-injection as women who receive that more intensive one-on-one training. I think in some settings, you might be able to do something like a one-on-one training with a community health worker, for example, which is obviously going to be less expensive for a program because many of those community health workers are volunteers. So there are still options, I think, out there for one-on-one training, but it's probably not practical to have that very intensive model on a large scale if you're relying on busy clinic providers.
Great. Thank you, Jane. Now we have a couple questions about the number of doses that were given to women to take home during the study. And as Alan mentioned previously, in this study that we're presenting on right now, each woman was given one dose to take home. Alan, I wondered if you could briefly speak to the number of doses that women are currently able to take home in the context of the pilot that's taking place in the Mubende district of Uganda, as well as the current ongoing continuation study.
Like Jane has said, for this particular study, whose results we are presenting today, women carried home one dose, really to ascertain feasibility and acceptability. But as a build-on to this study is the continuation study, where women are carrying 3 doses home. And this should cover them for 12 months of contraceptive coverage. And I think for the Mubende pilot, it's the same model we are going to use. One is for the pilot, 3, but for the evaluation, women will be carrying 2 doses.
Great. Thank you, Alan. The next question is for Jane. We've been talking a lot about Uganda today, but of course there's work on self-injection and on introduction of Cyanopress or DMPA sub-Q happening in many other countries, in many other parts of Africa. So one of our participants would like to know how the introduction of Cyanopress in Francophone West African countries has been different from the experience in Anglophone East Africa. Can you speak to that a little bit, Jane? So just a little bit about the experience of introduction in Senegal, for example.
Yeah, so Senegal and Burkina Faso both had a very different approach to introduction as compared with Uganda. In Uganda, the Cyanopress was introduced only through the community health workers. So it actually was not available at the clinic setting. It was only available for the community health workers. In Senegal and in Burkina Faso both, the Cyanopress was introduced at all levels of the health system. So from the health post, or the health hut, which is the lowest level, up to the health center.
Okay, great. Thanks, Jane. Alan, one of our participants would like to know, in the process of introducing Cyanopress in Uganda, did any particular healthcare professional groups oppose it or raise any concerns?
Not really. One, we did our research and all this work was informed by rapid stakeholder assessment and some formative research. So that kind of brought everyone on board. So by the time we were rolling out, all their interests were taken care of.
Great. Thanks, Alan. Now, I'd like to open the next questions to both of you, and I'll start with Jane. We have a few questions about disposal, which is a very important issue for self-injection. So we have a couple different questions. One question is, since the data on disposal in this particular study is based on self-report, wondering if we will, in the rollout of self-injection, include generating evidence to confirm actual practice regarding disposal. And this participant notes correctly that low-resource countries and communities have a lot of challenges already with waste disposal. So we need to think very carefully about disposal of sharps at the community level. Relatedly, another participant asked about involvement of village health teams or community health workers in disposal. So I'm going to ask Jane to talk a little bit about this first, and then we'll give Alan the chance to add anything that she'd like to.
Yeah, this is a great question. And disposal, I think, is one of the most challenging aspects of self-injection at home. What we'd like to do as we roll out the best practices, that evaluation, is we'd like to vary the instructions that are given for waste disposal. So try different approaches to waste disposal, one of which could be having community health workers, having some sort of central location in the village like the community health workers hut, or it could be at a pharmacy where we put a safety box and we see whether women will actually dispose of their product in those more secure locations. So I think we'll try different approaches to waste disposal as we roll out in the districts, because it really is a key issue and requires some creative solutions. The challenge here is that we don't want to set up something that is going to decrease the motivation to self-inject, like, for example, she has to return the product to the clinic. Now, for some women, it is feasible to come back to the clinic. She could just save up her doses, in her impermeable container where she's put them. She just saves that at home, and then next time she goes to the clinic, with a sick child or for vaccination, she brings her doses to be disposed of. The challenge there is that some women are not using with the knowledge, or using family planning without the knowledge of their partner, and so that increases the risk to her that it could be discovered. So I think we are yet to see what the best approach to waste disposal is, but we want to try out some different options as we move forward with the pilot and see what works best.
Great, thanks, Jane. And Alan, do you have anything you'd like to add on disposal?
No, I think Jane has said it all.
Great, thanks. Alan, we have a question from another participant who would like to know how many women became pregnant after self-injecting in the study.
No woman became pregnant in this study.
Thanks. We have a couple questions about the cost of the product. And I just want to say briefly that Cyanopress is currently available for $1 per dose to qualified purchasers in the 69 FP 2020 countries. Qualified purchasers include groups like Ministries of Health, procurement agencies like USAID, UNFPA. The price to individual women will vary based on the policies of a country. So Alan, do you want to just briefly say what the cost of injectables are for women in Uganda?
About less than $1.
In the private sector, right, Alan? And then in the public sector, all family planning commodities are free of charge.
Yes, it's about 80 cents. 80 cents in the private sector.
Okay, thank you. And we have another question about whether Pfizer has plans to file for FDA approval of Cyanopress in the United States, and whether any groups in the United States are working on this topic. I just want to say briefly that obviously PATH can't speak to Pfizer's plans. Do want to clarify that the drug included in Cyanopress, so the lower dose formulation of DMPA, is approved by the United States Food and Drug Administration. There was a great study that was published in the journal Contraception in October 2016 about the interest of women in the United States in self-administration of injectable contraception. So I would encourage anyone who's interested in that topic to find that article. And if you would like a link, you can email us at the address that's on the screen. Alan, we have another participant who would like to know whether any SMS technology has been used to connect women to community health workers for follow-up and questions with regards to this product. Can you speak a little bit about how many women in rural areas of Uganda tend to use mobile phones and accessibility, and what some options for the future might be? And I'll ask Jane to add anything after Alan responds.
From this particular study, our results were not significant that women needed any extra support, like telephone reminders or anything. But probably for some few who failed to remember their injection date, that can be an avenue that maybe can improve the results. We did not have that, like the practical support with the SMS, but they had calendars in their client booklet where they were able to schedule their injections. We know there are some efforts and other programs where they are linking up phone tech introductions with some support, like for maternal health, especially during the pregnancy period, but that we did not explore that deeply. And for the percentage of women that in rural areas that have mobile phones, it's really low for the rural places. This is where we were operating. I can't quote a particular percentage, but it's low. It's coming up, yes, but it's really high in the urban areas, not in the rural areas where we conducted this research. Yes, and just to mention that it's mainly the spouses or the men with the mobile phone. So many times these women have to share it if you need to contact them.
Great, thank you. And Jane, anything you want to add about that?
Just to reiterate Alan's point about, I think the SMS technology is a great idea. It's all, how well it works is all going to depend obviously on the context. And Uganda at this point is, the women who lack the phones are probably the women you most need to send that message to. So it's a little bit challenging in that context. And just to give an example, we have in our ongoing research right now, we have a study site where women may have phones, but they only charge their phone when they come into the larger town to go to market. So once a week, women come in and charge their phone, and you can use their phone until they no longer have until they run the battery down, and then that's it. So that's the kind of challenges that you face in a setting like Uganda in terms of using the SMS technology.
Great. Thanks, Jane. Thanks, Alan. Alan, can you speak to how long it took to train each woman in the study on average to self-inject specifically?
It took about, I think, I would give a range. It was between 30 minutes and 1 hour for particular training. Although for this study, because there were other study procedures, it was a little longer, but not more than 2 hours. But for only training, it was between 30 minutes to 1 hour.
Great. Thanks, Alan. And we're going to be exploring in some of the new rollout work in self-injection, what are some ways of streamlining that process. And again, as Jane mentioned previously, looking at things like group training as opposed to just one-on-one training. We do have a number of questions regarding HIV and DMPA, and I just wanted to ask Jane to briefly address what we know about the subcutaneous formulation of DMPA and potential increased risk of HIV acquisition, and what we did in this study based on the evidence to date.
Yeah, great question. This issue of the potential association between DMPA and HIV acquisition is something that we're tracking really carefully. As many of you probably know, the WHO is involved in the ECHO trial, which is a clinical trial exploring the possibility that injectable progestin-only contraception could increase the risk of HIV acquisition. And as I understand it, the results from that study will not be available until 2018. But we're all watching very carefully to see what's going to happen with that. I think it's important to note that DMPA-SC is not one of the products that is being tested in that trial, so we really won't know. It's the traditional DMPA-IM that is being tested. So we won't know whether SC has the same risk, if there indeed turns out to be a risk, as the traditional DMPA-IM. In terms of our research, we co-partnered with the Ministry of Health in conducting this research, and we had discussions with them and continue to discuss with them the possible heightened risk of HIV acquisition for the injectable more generally. And all the women who participated in this study were women who had already decided to use injectable contraception before they became a potential participant in the study, and the vast majority of them were continuing users. We did take the opportunity during the research study to reiterate to women that if they have a risk, if they think they have a risk of HIV acquisition, they should be using condoms. And we made condoms available to all the participants in our study, just to be err on the side of caution there. But to return to the original question, we're not going to know whether DMPA-SC has the same risk as DMPA-IM. And I suppose that'll be something that'll have to be modeled later.
Great. Thank you very much. So I'm going to just squeeze in one last question because we have so many that we weren't able to get to. And that question is, and I'm going to ask Jane and Alan both to speak very briefly on this. Can you just talk quickly about the role of privacy and discretion in terms of self-injection and whether that was of particular importance to women who either accepted or refused self-injection?
Yeah, great question again. We didn't see a significant difference between the two groups, the refusers and the self-injectors, in terms of whether privacy was a strong concern. So, but we had just a pretty small study. We only had 62 refusers. So we're hoping to look at that question in our continuation study, which has much larger sample, and see whether there are real differences between the two groups in terms of whether they see self-injection as enhancing or compromising confidentiality.
Great, thank you. And Alan, anything you want to add on that final point?
No, I think she said it all.
Great. Well, thank you, Jane and Alan, so much for all of that information. Thanks to everybody who submitted their questions, and we're so sorry we couldn't get to them all. If you do want to follow up with us, we encourage you to do so, again, at that email address, cyanapress@pass.org. And you can also visit our website and find answers to some of your questions, I'm sure, in our resources. So thanks for taking the time to participate in this discussion, and we look forward to continuing to engage with many of you.